So right now I'm going to describe the psychiatry portion, the delirium, alcohol syndrome, anxiety, panic disorder, and mood disorder. Okay, let's go for the first question from psychiatry. Look at this question. Actually, it is a 25-year-old secretary is referred to psychiatry clinic because she has been drinking excessively over the past 3 weeks. Okay. And she reports feeling down for about a month, crying frequently, having no interest in physical relations or work. And she admits to having had similar down periods in last 8 years. However, she also describes herself having periods of exhilaration during which she is gregarious, productive, and optimistic. Okay. So during this time, she says that she does not drink at all. So which one of the following is most anticipated diagnosis? So the diagnosis here, as you are all going through the exam, so you know that why these things actually happen. It is here, the answer is cyclothymic disorder. So how we can understand that it is cyclothymic disorder? I think we should first go for the question first. In every MRCP part 1, part 2 question, you should anticipate it for the question. Which one of the following is most anticipated? Then you will read the major depressive episodes, bipolar 2, bipolar 1, cyclothymia, or dysthymia. So you need to know these all definitions so that you can answer the psychiatric question, which one could be. So now I need to find out in this question that whether there is any signs of depression present or any signs of maniac or hypomanianism. These are the things we need to know. Look, I need to debrief this question, that how we can understand that the scale of this mood. We have a scale, you know, that for the mood disorder, we have two scale. One is the sadness, another is the happiness. This is physiology. But whenever you are more than sad, it is the depression. This is not normal. And when it became very severe, it is severe depression. That is major. And it's getting more bad, then it is suicide. Patient go for the suicidal thoughts. Similarly, in the mood, there is some happiness. So for the happiness, if someone more than happier, he or she is hypomaniac. Then some more severe happiness present, that is mania. And then they can go for the suicide. So this is the cycle. They describe actually these things. You know that mood is sad and happy, there is some scale. And in the scale of sad, there is some depression, there is some severe depression. And in case of happiness, if there is severeness in the happiness, that is abnormal, hypomaniac. More abnormal, mania, then suicide. So you will get the term like this cyclothymic, dysthymic, bipolar 1, bipolar 2 from this scale. This is one of the scale of mood. You know, the more sadness is depression, it's getting more dangerous, that is severe depression. From the happiness, the more you are getting happier, that is abnormal, that is hypomaniac, then mania. So now how you can classify these things from the structure, because you need to know first the definition, that is bipolar 1, bipolar 2, cyclothymia, and dysthymia. How you can understand this? The dysthymia means only chronic depression for 2 years. That is not major. Chronic depression for 2 years only. Okay. Now you are going for the cyclothymia. Look at the cyclothymia. You can see there is some cycle in thymic disorders. So thymic means actually euthymia is normal mood. Euthymia. is the normal mode. That is euthyroid. You can see in case of behavior, in case of mood, euthymic is normal mode. But in cyclothymic disorder, dysthymic disorder, only depression for 2 years. And cyclothymic, there is some cycle happening in the mood. So which cycle we need to know? How this can be transferred from one to another. Let's discuss with cyclothymic from the description here. Look at the description first. These are appearance of need measure if that is normal. From the normal mood, you are going for sadness, air, happiness, hypomania. And from sad, there is so mild depression, that is mild thymic disorders. There is hypomania. So what are the symptoms of hypomania? You need to know the symptoms of hypomania. Okay, and you need to know the symptoms of depression to just exclude these things. Similarly, you can see that bipolar 1 disorder is characterized by alteration of mood, look, mania, and depression. So bipolar 1 is the severity, more severe, the more severe depression and mania. So that is another stage, that is bipolar disorder. So more severe stage is the bipolar 1 and bipolar 2, and the less severe is cyclothymic. So you need to understand this cycle to understand this diagnosis. In part 2, I think from the part 1 you read these things, but in part 2 you should be more precise in psychiatry to diagnose this question, how you can diagnose. So you need to know this full cycle of moods. So normal mood is euthymia, the sad part, mild depression and hypomania. This cycle, if it happens from one depression to another hypomaniac episodes, so it will be cyclothymic. And if severe depression, that is major depression and maniac episodes happen, then bipolar classification will be done. Okay, but bipolar 2 is another one where there is some major depression with the hypomaniac also, that is bipolar 2. So major depression should be present in the bipolar disorder. So if you just summarize these things very easily, if I just remove this one, then you can just read that from the major depression to the major depression,
maybe
you need to go for the all DSM or more criteria. Is that not audible?
Like little like
my net is full. I think disrupting. Hello, is
Yes,
it disrupting?
Yes, sir. Sometimes.
Okay, so now let's go to the question. How we can understand this question? A 25-year-old secretary. There you found as cyclothymia is the answer. You should found the depression. Now look at there. She describes that she is productive, gregarious, optimistic. This is hypomania. So there is something, hypomania and depression, both are there. During this time, she does not drink at all. She is not concentrated in her daily works. So this mild depression and hypomania, this cycle is, that's why it is cyclothymic disorder. And this is at least 2 years. She is in 8 years. So you need to know the mild portion of depression and hypomania. So how you exclude the mania here? Can anyone tell me why there is no mania, but hypomania is there? In mania, there will be a delusion or a hallucination. There is no hallucination and delusion there, no? So there is no mania here. That's why bipolar 1 disorder is crossed. In bipolar 2, there should be hypomania that is present, but in bipolar 2, there is no major depression. The major depression patient will go for the suicidal attempt. Patient will have psychomotor agitation. these two, suicidal attempt and psychomotor agitation, are the major part, because you need to go for major depression DSM 5 criteria or more. There is 9 criteria. From the 9, you need to know 5 or more. In the 5 or more major portion, you should have psychomotor agitation and suicidal idea. That is major part of depression. So there is no such like suicidal idea here. So no major depression. If there is no major depression, there would be no bipolar disorder and no bipolar disorder 1 and 2, and also no major depressive episode. So A, B, C is crossed. Now dysthymia and cyclothymia. In the cyclothymia, there is only chronic depression with the hypomanic episodes. The hypomanic patient would be irritable, loss of inhibition, and patient would be sometimes very active. So gregarious, productive, optimistic is very active. But there is no delusion, no hallucination. Okay. I think is now you all can understand about this cyclothymic disorder. It is very neat, very much important to understand this question, because you can find out a lot of questions from here if you just read it out and debrief it very accurately. So major depression, bipolar 2, bipolar 1, cyclothymic, dysthymic, very important one. You should understand it. As you are all going through this mock test, I think it will be better for all of you if you read it very carefully, understand these things. Any question from here? This question, do you have any question who are live? For the first question, understand that cyclothymia disorder is a cycle of sad and happiness. Okay, I think you would like to do epileptic malignant syndrome or post-cyclic overdose. You should first go for the diagnosis. Okay, A, B, C, D. You should first go for that. Then you should read out the scenarios. Look, 68-year-old lady collapsed in trial room shopping mall. A department of psychiatry outpatient card was found in her handbag, together with bottle of post-cyclidine tablets. She was febrile with temperature 100, conscious but unresponsive to commands. Blood pressure was high, muscle rigidity. This is very important. The muscle rigidity and the temperature. So if there is any muscle rigidity and high fever, so there is something you need to know from this. Is there any neck stiffness or anything like that? So you can just cross the bacterial meningitis. You can cross the subarachnoid hemorrhage also, as there is no muscle rigidity in these things. So you have something like acute catatonic schizophrenia, neuroleptic malignant syndrome, or post-cyclic overdose. Okay. So what is the pathognomonic of neuroleptic malignant syndrome? The muscle rigidity. So muscle rigidity, one of the main diagnoses for the neuroleptic malignant syndrome. You should go for this thing, because if there is any overdose, there should be some other cramps or other diarrhea, loose motions, other things. GIT toxicities could be there, but nothing else. Only muscle rigidity and high fever. You should go for the only one diagnosis here, neuroleptic malignant syndrome. And for MRCP also, this is very important diagnosis. Whenever you found in MCQ question like neuroleptic malignant syndrome, you should go for exclusion for this neuroleptic malignant syndrome, present or not. So you have to read the neuroleptic malignant syndrome first, and another one is serotonin syndrome with this. So neuroleptic malignant syndrome is very important regarding this muscle rigidity. Whenever you find muscle rigidity, you should go for the neuroleptic malignant syndrome. Only one pathognomonic feature that is very specific for the diagnosis. Other things are very easy. Then there are certain drugs which can cause neuroleptic malignant syndrome. Okay, and neuroleptic malignant syndrome caused by certain drugs. You need to know the name of the drugs also. So there are some we have had for this causes. Right now, look why it is neuroleptic malignant syndrome. Only one. You should go for the only one clue, that is muscle rigidity. If you find any muscle rigidity, then with fever, the diagnosis is neuroreactive magnesium syndrome, nothing else, other than nothing else. Okay, so you need to go for this thing, that is neuroreactive magnesium syndrome, how it could be caused. Okay, I will just describe it. The neuroreactive magnesium syndrome should differ from the serotonin syndrome. The serotonin syndrome. This too is very important. You should read neuroleptic syndrome and serotonin syndrome side by side. It is very important. Read it side by side. Because there are some drugs, very rare drugs like levodopa, procyclidine can do, and some other neurological drugs. But serotonin antidepressants. With antidepressants, there are certain drugs you need to know to diagnose this serotonin syndrome. But here there are no serotonin syndrome present in the MCQ. So it is clean cut neuroleptic magnesium syndrome, very easier thing to diagnose. I think it would not be very difficult for all of you if you just remember muscle rigidity here. Other things you should forget. And only muscle rigidity, there are no other diagnosis of muscle rigidity except some Parkinson disease like disorders. So here neuroleptic magnesium syndrome would be the answer. I will show one chart of mine in neuroleptic magnesium syndrome in my lecture that is present in later part. Okay, let's go for this third question of psychiatry. This is a question you should answer with only see this thing. The first, which one of the following regions of the brain is most likely in this lady's condition? In pituitary, correct. This is neuroanatomy question. Locus ceruleus, nucleus basalis. So these are the things. So for the neuroanatomy, you need to go for the neuroanatomy lectures or neuroanatomy classes. Now, look, the diagnosis first. What is the diagnosis here? A 38-year lady complaining of emotional turbulence is referred for psychiatric clinic for an assessment. 1 year history of intense anxiety, fear. This is very important. Fear associated with palpitation, quivering, sweating, feeling suffocation. This is the pathognomonic feature of diagnosis. She does not give any clear. There are some other distraction point. These episodes last for 10 to 20 minute variety of settings. When she relaxed, she has no psychotic symptoms. And twice rushed to the emergency thinking she was having heart attack. This is another important thing. Similar episodes 4 years ago, which gradually subsided. Mother suffered from depression, father from ischemic stroke. General physical health is good. This is another thing. Physical health is good. It is important. She was alert oriented. So look, here the cognitive functions intact, mild impairment in the concentration. Why these are just telling that for the diagnosis of panic attack only. This is a diagnosis of panic attack disorder. Another functional disorder actually. No structural causes, something like that, panic attack. So this is panic attack where the physical health is good. Physical health good means his blood pressure was good. If hypertensive crisis occurs, then it would be pheochromocytoma. Pheochromocytoma. I will discuss these things if in endocrinology. That's pheochromocytoma, panic attack with the high blood pressure. Pheochromo, hypertensive episodes. But if blood pressure and physical illness is good, that is only panic attack disorder in the brain. Only in the brain, no other structural endocrinological problem. So in the brain, the panic attack would be, here the answer was here A, pituitary. Actually it is not pituitary, it is, the answer is D. It should be D. Okay, there is some mistake for the copy paste. It is not pituitary, it will be locus ceruleus. It will be, answer will be D, because the fear, anxiety, these are come from the fear circuit. There are some amygdala portion, amygdala with the area of hippocampus and others area with the locus ceruleus. These are the area where the panic attack occurs. So this is kind of difficult question. for the clinical science actually. But you need to remember this panic attack comes from the locus coeruleus. The answer not the pituitary. The answer would be the locus coeruleus. Here are some mistakes I from the copy paste portion. I think that is for the A. It is not A. It should be D. It should be D. That is locus coeruleus. But you need to what you need to just go through that whether it is a panic attack or not. If there is any panic attack, you should go for the brain anatomy. It is from the amygdala part plus hippocampus. You should picture or nothing. You should these local attacks. It is locus coeruleus. This is one of the difficult question, but you need to answer from the panic disorder. That is heart attack, palpitation occurs, suffocations, and anxiety fear occurs. For just diagnosing panic attack, this is very important. But from the panic attack, you should go for the whether any pheococytoma given or not. This is for the exam. Like panic attack, but blood pressure is very high and fluctuating with the some other symptoms of headache, fluctuating headache. This is pheochromocytoma. You need to diagnosis. Or other than this structural disease, if there is no pheochromocytoma, no blood pressure is well, no headache, other than this only panic attack present, then it is come from the brain, that is from amygdala and locus coeruleus and hippocampus. So these are the areas which create abnormal discharge from the brain. So these area are panic attack area. Okay, if you got the panic attack, I think that would be better for this question.